Started. Seth, you want to go?
Sure.
All right.
So, had a couple decent cases recently. This is a neat one we had yesterday, and this was a guy who had a abnormal echo, or sorry, came in with chest pain and had an abnormal troponin bumper, had a stress test. I can't remember which it was, chronic, or he had a stress test or had acute MI symptoms. Anyways, he was sent to us, and he has this very large, probably largest one I've seen. This is some form of sinus of Valsalva aneurysm. It's involving the left sinus. I have to say I've seen a few of these in terms of sinus of Valsalva aneurysms. All the ones I've seen have involved the right or the non. This is the first one I've seen involving the left. The other interesting thing is it's hard to picture it, but this thing is dramatically displacing the left-sided coronary system. So here's his left main, and then here's his LAD going basically all the way over and around this massive sinus of Valsalva aneurysm, and it was actually severely compressed. So here was some cath videos, and you can see that this negative space that's displacing it is the large sinus of Valsalva aneurysm, and here is that narrowing in the proximal LAD, and then here is just another picture of this huge one, and then they did at some point a ventriculogram, and you can see that this thing slowly starts to fill. So, and then another interesting finding is he has a bicuspid valve, and then associated with that, he has he has a little coarc. So, don't know what the relationship is between sinus of Valsalva aneurysm and coarc. We obviously know the relationship between bicuspid valve and coarc, but I don't know. I've not seen a sinus of Valsalva aneurysm this big, and the ones I've seen that have been very large usually have decompressed into with the VSD, have decompressed into the right ventricle or right atrium. Those are the ones I've seen. So we'll find out. He's going to surgery today. So that was a cool case.
You think this communicates with his LV then? Is that right?
Oh, yeah, no, it definitely commits. So here, yeah, it definitely, it directly communicates. It's just this big, and it's this very wide mouth, outpouching. Don't think it's a pseudoaneurysm. I just think it's and we got delays on it that show that it fills in completely. I really think this is a chronic or just a congenital process, this large sinus Valsalva aneurysm.
But I'm not quite clear. Does it have a communication with the LV or just the coronary sinus?
No, I'm sorry, not the LV. I'm sorry, just the aorta. There's no I mean, it arises from the ascending aorta in the region of the left sinus. So here's kind of our valve shot. It's a bicuspid valve. Here's our bicuspid valve. Here's the non-coronary sinus, the right sinus here, and then this big thing arising in the expected location of the left sinus. So there's no communication with the LV in the sense of between this aneurysm and the LV, but the LV obviously dumps into the aorta, which then dumps into this large aneurysm.
Got it.
Yeah, so that was the first case. This was actually this is a interesting case. This is a case where it's from an outside hospital. It's a young girl. I think she was 17, and one of our surgeons called me, and he's basically trying to describe this lesion to me, and he starts taking like cell phone pics, very bad cell phone pics of this study from an outside hospital, which is this study, and trying to tell me what I think it is. Obviously, it was better seen when we actually got the images, but on that, at least you could tell that there were some areas of just increased attenuation. There was some just abnormal. It wasn't just a simple cyst. There's some soft tissue within this lesion, significantly located primarily in the anterior mediastinum, displacing the mediastinum over. This thing got imagine extensive imaging workup. Here is, they got an abdomen pelvis, which is nice because you could just see a little bit of more of the mass, that there's some septations and some kind of soft tissue in there. And then they got an MRI, which I won't beat this down. You know, there's all these images, which I'll send. But this is T2 weighted sequence, and this is not a simple cyst. It's multiloculated. There's some soft tissue component here. And there was a question, I don't really, when we did the fat sat, it didn't really saturate out for me. I mean, there was a questionable amount of saturation out in this area, but this was pretty dark on the non-fat sat as well, this area up here. And that corresponded to a focus of hemorrhage on the T1 weighted imaging. So long story short, complex lesion, this was taken out. And even though there's really, here's a vibe, about a minute post-contrast, you can see how complex this thing with these areas of enhancement. Anyways, this turned out to be a myxoid liposarcoma. And it's interesting because there's really, at least in my mind, looking at it, no significant fat in this lesion. You know, I've only seen a few mediastinal liposarcomas, and you could question, you know, where does mediastinal fat become this lesion? Is this mediastinal fat? I mean, here on the MR, a lot of this, you know, this measure fluid attenuation on the MR is fluid. I mean, there may be in retrospect fat. I think it's hard to call that, but definitely not a fatty, you know, dramatically fatty lesion. You know, you get some area, yeah, maybe fat in there. But anyways, this was a myxoid liposarcoma. And they're very, you know, most liposarcomas I've seen, either de novo from the AFIP, have clear macroscopic fat. So that was a little less, that was interesting. And then this was a case we had a couple of weeks ago. And I've only, you know, I've only seen this one other time, and this is nowhere near as pretty. This is much prettier than the case I've seen. So this is a woman with these, or this large multiple lateral thoracic meningoceles. You see widening of the canal and widening of the neural foramina. And this patient does have, you can see here the skin lesions up here. And this patient does have neurofibromatosis, and that is associated with lateral thoracic meningoceles. So this is, for me, the nicest case. I've only really, again, I've only seen this one other time. This is by far the nicest I've seen lateral thoracic meningoceles. And I think only the second or third time I've seen them. There weren't any other, I don't think there were any other dramatic findings elsewhere in the lungs to suggest NF, but minus the skin lesions and this lateral thoracic meningocele. And then lastly, I just want to show this because it's just, to me, this is the nicest I've ever seen this, and it's not a hard, oh, come on, open up for me. It's not a hard diagnosis to make, it's just, it's be, come on. All right. Let's see how this works. So this is a, let me see if I can move this and play this. So this is a guy with had a history of constrictive pericarditis, and this is kind of going slow, I apologize. And this is just a beautiful, so this is a real-time sequence that's kind of going along. And really the best sequence to, and the only one you really need to make the diagnosis of constriction in my mind is this, you know, is this real-time image. And I prefer short axis. You can do it in the 4-chamber where you do this real-time imaging, and during inspiration, an early inspiration, you'll see this dramatic bowing of the septum, secondary to increased volume. During inspiration, you decrease right atrial pressures, you increase volume into the right atrium, the right ventricle fills first, and then because of ventricular interdependence, you get this just very rapid increase in right ventricular pressures compared to left, and lead to this, again, dramatic bowing here during inspiration, which you can see very, very, very early in inspiration, this really pronounced bowing, like right there. So when it speeds up regular time and you play it in a regular viewer, it's quite nice, and the nicest I've seen. I've also included a bunch of other stuff, including a CT and a plain film, but again, the diagnosis is pretty much, if you want to confirm constriction, not just calcific pericarditis, but confirmed constriction, that really is the best sequence to run. But anyways, those are my cases, and that's it.
Thank you, Seth. Those are awesome. All right, who's up next?
I'm happy to go. It looks like Brent and Howard and you and David, but I'll show a couple here.
Go ahead.
You trying to upstage me?
No,
And no one wants to upstage those cases.
those were pretty fantastic cases. But yeah, I'm gonna try, but we'll see. This is another iatrogenesis imperfecta case. Credit my fellow for picking this up. So you can see there are a couple different radiographs here. This is back in September, and this is more recent. And in the interim, he had some workup done at an outside hospital. And on this radiograph, you can see there's maybe a little bit more fullness in the right hilum, and some subtle junk next to it in the lung. And the history was he came in with hemoptysis, and I'll withhold the rest of the history for a moment and show you the CT that they did just after this radiograph. And you'll see this guy's like 80 years old, and so he has this nodule, which is suspected probably a little adenocarcinoma. But this was the ground glass and such here. And then my fellow, when he read this, he noticed that there was this little blush right here, and this was kind of a more discrete lesion right there. And you can see it's coming from, looks like this bronchial artery goes right into that little blush. And so the patient came in with hemoptysis, and about 3 weeks ago he had a bronch and an endoscopic biopsy of this nodule, which was non-diagnostic, but he also had an endoscopic biopsy of a right hilar lymph node. And so my fellow correctly surmised that this was probably a bronchial artery pseudoaneurysm, which explained his presentation with hemoptysis. And I will show you the angio images here. This is just a I guess proximally selective bronchial artery injection, and you can see this thing lighting up. And then they do a more selective, and there you can see this partially thrombosed bronchial artery pseudoaneurysm. And so then they put some coils in it, and it's not filling anymore. And then, of course, yesterday, just because they can, they got a follow-up radiograph or CT, and you'll see now that there's no filling of this. So this is, I think, the first iatrogenic bronchial artery pseudoaneurysm I've seen. I know I showed a case of bronchial artery aneurysms that wasn't sure why they were there, but this is, I thought, a really cool case. And something else we can add to our iatrogenic list. So, Seth, that one's not going to stage you up, but it's a good case.
No, I've never seen that either.
This one.
Oh, this is going to be good. It's old films.
Yeah.
Well, this is going to be good.
As you can see, 2005 is when this lady's issues start. And this is one of those diagnoses, the eventual diagnosis that just kind of hoses us every time. And it got me this time, too. You can see that she's got this big hepatic flexure soft tissue mass. And this was back in 2005. And so they took this out. And I don't even know. They did partial colectomy, all this other stuff, and it was diagnosed as a spindle cell neoplasm, possibly an inflammatory myofibroblastic tumor, and that was 2005. And that was somewhere else. And then in 2007, she develops these strictures, as you can see here. And I guess they biopsied something and got spindle cells and thought that she had a metastasis, to her liver that was obstructing. It's a kind of a confusing story. But anyway, she's had 3 dozen or more ERCPs since then, every year, putting in biliary stents and whatnot. 2011, she then has, this CT shows that her lungs are reasonably clear, and you can still see she's got the biliary stents and such. And then she came into the ED this year, and now she's got this consolidation on the right, some nodular foci consolidation on the left, and the question was, does she have pneumonia? Does she have something else going on? I thought maybe she had some lymphadenopathy here. Then she got the PE study, and check out her lungs here. So it's been several years, and I think this is all just her dilated azygos arch. But I certainly was not crazy about the pneumonia once I saw this CT. I think this is much too mass-like. And I was a little worried that she had even maybe a little bit of lymphangitis, lymphangitic carcinomatosis. And of course, the history I got at this time was that she had a spindle cell sarcoma or spindle cell tumor. And I didn't really know much else. And you can see even this paravertebral stuff here. She went on for PET a couple days later. And let's see, and not surprisingly, all this stuff is hot. So I thought this was going to be metastatic disease. And I'll just show you, it was not metastatic disease. Here she is 2 months later, and her lungs have substantially improved. So in between this, they re-looked at her original path from outside, and somebody put all this together and did some stains, and this is all IgG4 related disease. And we actually biopsied the lung a few days after this, and it was IgG4 related disease in her lung parenchyma too. So the original tumor wasn't a tumor at all, that they think it was all just this big mass of IgG4 related systemic disease. And so probably her biliary, she probably has some sort of biliary, whatever it is, PBC or whatever, that can be associated with the biliary strictures associated with IgG4 as well. But yeah, this one totally got me, because I had been given a history of cancer and didn't have a reason not to believe that. So,
Travis,
yeah.
Travis, you've got all this stuff in her mediastinum. Do you think she's got IgG4 soft tissue in her mediastinum, and is it pinching off veins by any chance?
Yeah, it's not pinching off the veins. You're trying to explain the septal thickening that we saw here?
Yeah, and we have a recent case of a guy who has pulmonary hypertension, who's got something pinching off his pulmonary veins. He's got a lot of mediastinal soft tissue, and IgG4 disease was our consideration. So I was just curious. I think it's just lymphadenopathy involved too. There were internal mammary nodes. All of this stuff was hot, but this is the most dramatic case of lung parenchymal IgG4 that I've seen. How about the mediastinum? Did it light up too with a?
That's what I'm trying to look at. Unfortunately, this was not a fused PET because the patient was an inpatient and had just had that CT. I'm trying to look like for some of these.
Travis,
this is some of the paraspinal stuff. Yeah.
Does that oh, that's different dates. Never mind. I say if you launch the attenuation correction CT with it, it'll use it. But
yeah, unfortunately, that's not gonna be helpful. But yeah, sneaky case of IgG4 going all the way back to 10 years ago, and she's been doing much better on high-dose steroids, including, as I showed you, her lung disease has improved and everything else has improved too. So yeah, I'll show these in succession just really quick, because this is Jeff. This is from our collection of scimitar cases, and this one I just showed just because it's when I was digging through, I finally found one of these variants of scimitar. But you can see here is a scimitar vein. It's draining here somewhere into the IVC, but you have this cool little part of the right lung that herniates cross midline, and you can even see the airway coming off here, off of the right lung. And this is a really funky right main stem bronchus. If you see that it gives off really one lobe into the actual lung over here, and then I don't even know what this little branch is. and then this one that goes posteriorly. And so this is the best example I can find of a horseshoe lung in the setting of scimitar. I think from the reading I've done, it's supposed to connect to the left lung. There's supposed to be like connection of the basilar segments, and here you can still see there's a clear, fissure or I don't know how many layers of pleura there are here, but I still think this qualifies as a horseshoe lung. I don't know if anybody else,
So,
David, if you agree or not.
David and I were.
Yeah, so
Go ahead, David.
So I had a case that looks very much like this, except not so much motion artifact, that I sent to Jeff today. And so this is called horseshoe, but I think it should be horseshoe in quotation marks because the analog, the horseshoe kidney, there's actual fusion of parenchyma across the midline, and those kids have a number of bad disease. And true horseshoe lung also is not compatible with life. The kids that have real horseshoe lung, that's fusion of parenchyma, really have a lot of congenital abnormalities and they don't survive. So this is really pseudo horseshoe because the lungs are still separated. There's no parenchymal fusion.
That's kind of what I was thinking too. This was just a case I found. I think it's from the Blue Journal a couple years ago, but you can see here, this looks very similar. This is in an adult, but again, they're calling this a horseshoe lung, but there's not really that true fusion.
True.
So I like your term pseudo horseshoe. So I guess this is one of the European respiratory journals, but yeah, that was one, and then I had another one too. That's the two of them both in young kids that had imaging here. This one was only an MR, but you can see on the black blood images if I find them. Where's it's I don't even know where they are now. Here, yeah, you can see very similar, same thing. I think you can see that projection there. This patient actually had a VSD as well associated with their scimitar. But yeah, I just wanted to show those really quick just because it's one of the rarer associations, and we'll call it pseudo scimitar or pseudo horseshoe from now on. So, all right, Jeff, I'll stop there just since there's others. I can do more later.
Okay, thanks. Thanks for showing those. Yeah, David and I were talking about that yesterday over email, the pseudo horseshoe. All right, Brent or Howard or David?
I have one case I can show.
All righty. Are you ready to accept the screen?
Okay. You have to invite me. Make it nice. Okay. Okay. Can people see a CT scan?
We do.
Okay. So here's the scout view of this man who has some respiratory distress, some shortness of breath after heart surgery at an outside institution. I noticed that earlier Seth made a big point about this being an outside case, which explains all sorts of things. And this fellow has this elevated left hemidiaphragm, so they wanted me to do fluoroscopy. I don't have any chest radiographs to show you just the scout view here, but he does indeed have an elevated left hemidiaphragm. He's got pleural effusion on the right. He had mitral valve replacement and tricuspid annuloplasty. This thing looks kind of expanded. I wonder if it's really doing the job that an annuloplasty should. So if we look at other imaging here on the same person, we look at the cross sections for Cruz thickness down here, which is, since I was asked to do as pleural of his diaphragm, I always check the available imaging on this guy. And if we go down here, we have some thinning of looks like thinning of the Cruz, but we get to this point, we see there's actually pretty good Cruz thickness up here on the left. And I can show you this in coronal. Although he's got a thin diaphragm tissue at this level down here, it looks very wispy and would definitely make you think that this could be atrophied. If we look at a sagittal view, we will see that anteriorly he's got quite good thickness here of his diaphragm muscle. So this predicted to me that this was, despite the elevation, was not going to be paralysis. But we were asked to do the fluoroscopy of his diaphragm anyway, so I'll start with him standing here. And here's a series of images, and you can see that on deep inspiration he's really got quite good excursion of this left hemidiaphragm. And despite the pleural effusion on the right that obscures diaphragm, we can still see that the effusion is moving in the right direction, so we can intuit that the right hemidiaphragm is moving as well. So he's got actually pretty good excursion of this left hemidiaphragm. we include a lateral view because the most vigorous diaphragm motion is posteriorly. So here's our elevated left hemi diaphragm with a lot of gas in his stomach underneath. And you can see that he's really got quite good excursion here on deep inspiration, and it's moving the same direction as the other side. The effusion is also moving down. You can see that he's got very vigorous chest wall motion. He's really, he's really sucking hard to take in a deep breath there. So once again, the lateral view is very helpful in this fluoro here because the most vigorous motion is posteriorly, which is going into the cruise. If you want to pull the diaphragm down, the fibers that are directed in the best direction to get the most mechanical effect pulling down are the fibers of the cruise. That's really where most of the diaphragm motion comes from, and it's really just anchored elsewhere, but it's really moving largely through the function of the cruise. So indeed, seeing some normal muscle looking anteriorly on the CT scan, and around the aorta where the cruise muscle is, helped us predict that his diaphragm motion would be normal on fluoroscopy. We could have, if this person had difficulties in cooperating with the fluoroscopy, we could have used that information to suggest that this diaphragm, despite its elevation almost front to back, was not paralyzed but was eventrated. And we put him supine, which is adds to the stress test of diaphragm fluoro. It loads the diaphragm and it prevents people from getting that false orthograde motion that is just from relaxing abdominal muscles, maintaining themselves in expiration using their abdominal muscles, and then when you ask them to take a deep breath, they relax their abdominal muscles and the diaphragm passively falls, but it looks like a nice inspiration. Putting the person supine defeats that, and so if we don't have motion on supine, then I begin to suspect that I was really seeing what I thought was good motion of the diaphragm standing was actually just passive motion of the diaphragm from using abdominal muscles. So here he is supine, and if he still has good motion on supine, then we know that there's actual diaphragm function, and lo and behold, he's got pretty good excursion here on supine imaging. So looking at the cruise is good. You have to look at the diaphragm muscle thickness anteriorly as well. If you've got this very large eventration here which stretches out some of the diaphragm and makes it look like cruise thinning. So look where the cruise really is near the aorta, and then look anteriorly for diaphragm muscle thickness near the sternum too. Okay, so diaphragm is my second most favorite organ, and you're not supposed to ask, but if you know Woody Allen movies, you know what his first favorite organ is. So I've lifted that from Woody.
All right. Thank you, David. That was great. All right. Howard or...
Okay.
All right. Go to Howard.
Okay, I'll start off with this case. Let me see. This is a radiograph on a person that is 5 days out from surgery, maybe 4 days out from surgery. So he had a cabbage. He obviously has had his left atrial appendage clipped. But this is a pretty dramatic case because we typically don't see this so soon after surgery. But of course, his sternal wires are very abnormal. So here are some here. Here are some here. There's one there with a lot of lucency between them. So of course there is substantial disruption of the surgical incision. And you can see the big gap between the two parts of the sternum. Some of the sternal wires have torn through but have remained with the left part of the sternum. Some have torn through but have remained otherwise intact with the right side of the sternum. And then one particular wire stayed with the left side of the manubrium up high. So a pretty dramatic case of very early sternal disruption after surgery. I think maybe the most dramatic one that I've seen that I can recall, both in terms of how dramatic it is, but also very soon after surgery. So of course he was admitted to have that attended to. So very soon after surgery.
Howard, did he have mediastinitis and an infection, or was it just from sheer trauma force? Or
I think I don't really know why it the wires tore out of the sternum. So there's a little bit of fluid and a touch of air, but no discrete abscess or anything like that. And you can see that there's a little incision there, but no, this is just what it looks like. It just tore out like that.
I wonder if there was vigorous coughing or something like that that really stressed.
I don't know. Yeah, I don't know what happened.
Wow.
He had surgery at the hospital, was transferred here to fix that, and I'm not entirely certain what happened. That result.
The surgery was just a couple of days before, you said?
Yeah, I think 6 days before the imaging, 5 or 6 days. Yeah.
That's definitely the earliest I've seen. Because I usually think, I can't remember, is it what, 2 to 4 weeks? That's kind of what I use. I don't know if that's, what was written, but that's kind of when I think about it happening.
And even later, weeks, months later.
Yeah.
Sometimes, yeah. That's early. This is way early. This is a nice example of a patient that developed, as best we can tell, a cough. She just wasn't very well. I think a cough was, and maybe some dyspnea was part of her presentation. And this is a radiograph from April of 15. This is one now. So the difference is that she's got some ill-defined opacities, poorly marginated opacities, non-segmental, patchy in both lungs, and inflation of her lungs is a little diminished from the comparison exam. This is what on 5mm cuts the opacities look like. So there are multiple, patchy, multilobar, ground glass, mostly some consolidative opacities in her lower lung zones. The thin cuts pretty much show the same thing. One clinic note said that she had Raynaud's. Another one said that she did not. But they began to do the usual things, which includes a panel of lab exams. And the one that's relevant that came back positive here is this particular anti-synthetase antibody. So not Jo-1, but this EJ antibody. This is the only one that is positive. So based on her presentation, this particular antibody, which is the only thing that she had that was abnormal, and maybe Raynaud's, she was diagnosed as likely an anti-synthetase syndrome. Certainly the imaging findings that we see are consistent with that. I think that we assume that what's in the lungs on an exam like this is an interstitial cellular pneumonitis, maybe a lymphocytic interstitial pneumonitis, organizing pneumonia, maybe combinations of all of that is present. And she was treated with steroids, and here is December, and she's definitely better. So she does carry a clinical diagnosis of the anti-synthetase syndrome, treated with steroids, and definitely better over time. So that's what I always assumed. She didn't have a biopsy. I don't think one was necessary. But I presume that that's what the pathology is. Does anyone have any other comments about what the pathology is thought to be in this particular syndrome in the lungs?
I like your cellular process. And if you look at the follow-up, she's got a nice, very subtle subpleural sparing, so probably along that NSIP spectrum, but clearly responsive. And there's probably
usually, some OP. Is that what you were going to say too? Usually a mix.
Mixed.
And Howard, usually the anti-synthetase antibodies are mutually exclusive, so you're usually only positive for one.
Oh, I see that. I didn't know that.
Right. So obviously, Jo-1, PL7, PL12 are the most common ones. Yeah, I've never seen EJ, but there's OJ and KU and a bunch of other ones too. So that's great.
Yeah.
Do you have a anti-synthetase program over there? I mean, why do you know all the antibodies?
I know for partly for the connective tissue disease paper I wrote last year, and we see a ton of this in our ILD program too.
Like I can barely remember the basics.
Yeah.
Yeah. This is a patient that came back with an interesting presentation. So the history is important here. She's got a history of a lung cancer treated with a lower lobectomy on the outside. When she came back, she initially had a non-contrast CT. And let's see if we pick up, say, the chest, you can see there's something wrong here. Abdomen, this is with contrast. So you can see she's got a process that involves the lower chest and that and this. And you can see that the liver is really involved too. So there's intrahepatic parenchymal, but also basal chest. And I think the initial diagnosis was thought to be an infection. I'm not sure exactly what it clinical.
Howard, we lost you.
Yeah, I think we did.
Going through the chest, or started in the chest and going through into the abdomen. So they put a drain in that.
Howard, we're losing your audio. David, or
Current squamous cell carcinoma.
Howard?
Yeah, I can't hear his audio.
okay, so
Right.
Howard, there's something with your connection because you might want to like log out and log back in. We've lost your audio.
Okay. Can you hear me now?
Yes.
Yep.
Okay. So, all right. Did you hear what I said about the presentation in the liver here?
We got
where
the,
there's abnormality.
We haven't heard anything for the last about minute and a half.
Okay, just switch to somebody else.
No, it's fine. We can hear you now.
working
You
now.
can hear me now? Sorry. Okay. Not sure what happened. So again, just briefly in summary, she presented with this process. They thought it might be an infection in the liver, abscess traversing the diaphragm. So that's abnormal, this abnormal, and then the liver. But when they drained this, they got squamous cells. So this turns out not to be an infection, but rather recurrent squamous cell carcinoma traversing the diaphragm.
Huh.
So there's the, sorry. There's what basically happened right there. So history of cancer, recurrence, but a very strange form of recurrence going through the diaphragm into the liver.
Were the margins positive from her original lobectomy?
I don't know. Let's see, it was back in 815 was when she had that.
Don't you
And
think
then she came back here in July.
positive margins, or I mean, usually if you do a lobectomy and you get positive margins, you either go back and clean it up or you treat the margin.
Right. Yeah.
Didn't look.
I couldn't find any more details about that history that you see there, right there. I don't know what happened or exactly what was found. No, I don't. All right, Jeff, those are mine for this week.
All right, thank you. Brent, do you have cases? And I also have some.
Yes.
All right.
Okay, let me choose the right window here. Okay, can you see my window? Okay, can you see the window?
Yep. Yes.
Okay. So this is a very interesting case. I've never seen this particular variant before, but when I first saw this, I saw an interesting vessel that is crossing across midline here, and you can follow this to, and I should say that first of all, this is a patient who has a coarctation. You can see the aortic coarctation right there. You can also see that there's a little patent ductus right there, and that was really the reason for the CT. But you can see that there's an abnormal vessel that is crossing from left to right, and it's really crossing behind the pulmonary artery, and you can trace this to pulmonary veins, and you can see the pulmonary veins draining here into this this large venous structure, and that crosses midline. And then I thought that it was going to be a variant of anomalous pulmonary venous return draining into the azygos, but it's actually not. It's here's the large common vein here that picks up some venous drainage from the other side as well. You can see right here it's picking up some left upper lobe pulmonary venous drainage, and then it also drains not to the right side but to the left side back into the left atrium. So you know, this is a really interesting, I think, meandering pulmonary vein that's meandering from one side to the next, and really not a shot, just a dramatic meandering pulmonary vein. But I wondered, you know, has anyone else ever seen this particular variant of a left to right or right to left crossing midline meandering vein?
No, I don't think I've ever seen that.
Brent,
No.
are there normal right pulmonary veins if you go down lower?
Yes. So here's the inferior pulmonary vein, and here's the superior pulmonary vein, and then that's actually what's accepting that. So I'd never seen this before, and around here I haven't talked to anyone who's seen this before either.
You know, it's kind of reminiscent of Howard showed some examples of the top or roof pulmonary vein, where it's a small vein that usually drains either the posterior segment or the superior segment and kind of slides behind the bronchus intermedius or right upper lobe bronchus, except it goes into usually to the right atrium on the right. But it seems like it's in that same pathway, except yours is huge and crosses the midline. But I don't know, Howard. Kind of wonder embryologically if that's how it's derived.
I don't know. This happened before.
So this is Kenny's law, which is if there's one anomaly, look for all the others.
Yes. Yeah, I'd never seen it. And usually the top pulmonary veins that we see, they'll come in like about right here, and they come, as you said, behind the bronchus intermedius. But this kind of goes into what would be the superior pulmonary vein. So I don't know, I've never seen this, and I just thought it was especially dramatic.
Was the atrium okay? There's no ASD or anything like that?
No ASD. So
Brent, there's no left superior pulmonary vein. Is that what you're showing?
Well, yeah. I mean, this is kind of where it would be.
I mean, normal. Yeah, no normal entrance into the left atrium of the left superior pulmonary vein. So that's where most
of it's draining. So you see some other branches here that are draining, as if they would normally drain into the superior pulmonary vein. But then the problem is it also accepts all the flow from the left side.
From the left upper lobe. Yeah.
Yeah. I just.
Wow. Yeah, because
when it enters the mediastinum, it looks as if it's trying to be a conventional left upper pulmonary vein, and then it this trick of instead of joining the left atrium, it crosses to the other side.
So the original meandering pulmonary vein that Larry Goodman described, I think, was a right pulmonary vein that crossed left of midline, correct? Because it was like a pseudo scimitar. But yeah, this is the opposite. This is a left-sided vein crossing to the right.
But those meandering pulmonary veins that we've talked about in this conference before have been in the lung. They've not been in the medias. They've not crossed the mediastinum.
No.
No, but that was the original description, wasn't it? Was the one that a right-sided one that crossed midline and crossed the mediastinum and then drained into the.
I don't think so. I don't think so. We should look that up. I don't think that was his original description. Component.
I was under the impression that the ones that I've seen that I've called meandering, I've just seen them on, like not cross midline. They just kind of take this weird, crazy course on one side. But it may be true that I just haven't seen one cross before. That may be the original description. I just need to look that up too.
Hey, Brent, the bronchial anatomy fairly conventional. Was there any, or the lobar anatomy?
I thought so. I mean, here's what looks like middle lobe, and here's the upper lobe here. It looks like it was normal on the right, and longer bronchus here, and then it looked normal to me.
Yeah. Okay. Just wondering if this was in that spectrum of scimitar, meandering vein variant, pseudo scimitar with some airway anomalies too. Well, that's really cool.
And you said the right ostia, the pulmonary venous ostia, are normal, or they are normal?
I mean, here's a normal inferior, and then
that's normal. Yeah.
yeah, and then here's what would be the superior, but then it accepts all the rest of the flow. So
Yeah, because sometimes these meandering veins, I look and I see that the ostium, if you look down, there's often or not often, sometimes a stenosis of the pulmonary venous ostia right near the where it meets the left atrial appendage. I mean the left atrium, and so it's just kind of a accessory pathway. But this is clearly not.
look at this. I mean, this little vein, drains into this, segment as it crosses too. So it's very bizarre.
Yeah, that's weird. That's just weird.
Let me just show. Cool. Yeah. What's that?
I said it was cool. That's really
thanks. Cool. Let me show one or two more because I have these were like the most exciting week for a while, So I just wanted to make sure I show. So this is an interesting one. Look at the free floating aortic thrombus here in the descending aorta, and it's just kind of hanging out. This was originally thought on a partial kind of C2 test. It was an abdominal CT. The thought was, could this be a dissection? Because they didn't have a full view of this. So, I thought, could this be a dissection? It's actually, it's obviously not. It's a free-floating adherent thrombus. It's adherent right there, and it goes down there. And then, obviously you want to look for embolic phenomena and go down to this was a full patient came in with leg pain, and you can guess where this is going. You can see that the profunda right here, it's easy to even bypass it, but the profunda right here is occluded right there, so that's one embolus that this patient had. And then go down to the lower extremities here, and then you can see that the anterior tibial and the posterior tibial both are out, and they abruptly terminate, right here. And then you can't even see the anterior tibial that terminated earlier. So this is a really nice example of a free-floating aortic thrombus and causing embolic phenomena. And you can see that the bowel doesn't look good. So we checked out the SMA, and there was no thrombus. I should tell you this patient has Crohn's disease. So presumably this was due to Crohn's disease. It may also have been due to some emboli that got thrown and then dissolved, but we didn't see any large emboli in the SMA, but I just thought that was a good case of a free-floating thrombus there.
So Brent, was there any source of these thrombi more proximally, such as left atrial appendage or something like that?
No, not. We saw
be secondary, not primary.
We didn't see anything in the left side of the heart. We didn't see anything in the atrial appendage there or the rest of the atrium. These it looks like there might be a lead point, some atherosclerotic disease there or something. We see that as a lead point sometimes. But yeah, we didn't see anything that was causing this. It was just kind of a free-floating adherent thrombus there. So. Let me show you this. This case I really like as well. This is a man in his 50s and had chronic shortness of breath and has this dramatic.
Not seeing the screen yet.
Has this dramatic appearance here. This is dramatic appearance, chronic shortness of breath, and these opacities got worse and worse. And of course, there's a lot of septal thickening, well-defined geographic ground glass accompanying that, and a crazy paving distribution, and you have some areas of consolidation. This was not infection, these more confluent areas. This was a part of the oral process. And they did a biopsy of this, and I'll tell you that his occupation is a construction worker, and he works with some saw material, and what was found on the biopsy is alveolar prognosis, but also aluminum particles. So he was exposed to aluminum dust, and presumably this is one of the rare but reported cases of aluminum dust inhalation causing alveolar prognosis. And he went on to have a lavage, whole lung lavage, and this got much better. I don't have a follow-up radiograph, but just imagine a relatively normal radiograph. This is an interesting case of aluminum dust-related alveolar prognosis.
Hey,
Wow.
Brian, I showed a case of this earlier, same thing, aluminum, and the lady had worked in a door manufacturing plant here in Wisconsin.
Oh, now I do remember that now. That was a
Yeah,
few months ago. I remember that.
you're right. It's a rare cause. Silica is another one, but it is reported in the literature. So
I now remember that. Yeah, that's okay.
Yeah, I've seen silica. I haven't seen aluminum. That's pretty cool too.
And here's my favorite. Are you ready for an even better case?
We'll do one more, and then Travis pulled up the Goodman paper.
This is the last one. Let me show you the. Let me bring this up. Last one, I promise. This one I was really excited about this case. So this case.
Nice.
So I thought, wow, this one is pull this up without looking at the history first. This woman has a lot of silicone granulomas in the breast tissue here. Maybe had some medical tourism causing all these dramatic calcifications, stranding in the soft tissues. Then I realized this is a man. This is a man, not a woman. And then I thought, well, this may be a transgender woman and a male who was doing some contouring, body contouring with free silicone. It's actually not that either. This is actually an unfortunate gentleman who had a history of a bilateral mastectomy, and it was radical. You can see, you don't see the pectoralis really here at all. And, this was for what was later found to be just gynecomastia bilaterally. So very unfortunate. I don't know how that happened. This is not from our institution, not a patient from our institution. However, this patient also came in with a very high hypercalcemia. So when I saw this, I thought, well, this is a granulomatous hypercalcemia, which this is thought to be, and it's unclear whether this patient is actually injecting free silicone, or there's some indication that maybe some of this is mineral oil on top of that, and I'm not sure. You see this very lucent globules. So I'm going to get more history on that, but presumably this is some sort of reconstructive sort of process injection causing, a granulomatous injection, granulomatosis with a hypercalcemia related to that. So I just thought that was a really fantastic case.
And
Wait, so he had breast injections because he had a mastectomy for gynecomastia?
Well, that's that he had mastectomies, and he had this radical chest surgery, and then kind of the notes go blank, and I presume that what happened was there was some illicit sort of injection of either, I believe silicone here, to try to reconstruct the chest. And
that's very interesting. Because most okay, that's awesome.
Yeah.
What do his lungs look like?
Oh, yeah, I mean, we didn't. So one thing is he has some severe emphysema. So I don't know if this is a particle-related emphysema or if he has some sort of. He is a smoker, but it certainly has a lower lobe predominance. So is he alpha-1 antitrypsin deficient as well? It's hard to say, but he doesn't really have a pneumonitis due to silicone injections, but he does have an interesting, lower lobes.
That could be injected tablets again around here.
Stuff. Yep.
Yeah.
All right.
Anyway, thanks.
Travis pulled up the Goodman article on the meandering vein, so I'll let him share that.
Really quick. So here, this is the original article from the 70s, and this is when they described this right-sided meandering vein mimicking scimitar, and you can see these arrows kind of highlight the course of the vein, and they describe it draining here under the left atrium. So this is their description. They say that it, instead of piercing the diaphragm, I think they were thinking it might be scimitar, continuous to the larger mid-thoracic vessel, drained cephalad, crossed mediastinum, entered the left side of the left atrium. So I think this is kind of that Brent's case is really a mirror image of that almost.
Yeah, so transmediastinal meandering vein.
Yeah, right.
Wow.
But the other cases that we've discussed in this conference have not crossed the mediastinum. They've been in one, and they've sort of looped around in a bizarre way in that lung.
Agreed.
Yes.
Yeah. So crazy. I don't know, Seth. He might have upstaged us all.
Yeah, sorry, I think we did.
Yeah, that vein was pretty good.
Yeah. Some great cases today.
Yeah.
Oh.
All right.
I actually, sadly enough, I had like 3 or 4 that come in the last 2 days that are better than some of these I showed. It's random, but I'm saying like in October, November, there was nothing. Like it was just a complete desert of goodness, and then some fascinating things have come in the last week or two.
Yeah, patients knew when you were away at RSNA.
Yeah,
that's when they came in.
Exactly.
Okay, well, it's about 3 o'clock, so I will start next week. I've got some nice cases. They're not quite as good as the ones, but I got a couple fun ones. So I'll start next week, and I got some cases sent to me from other people, so I'll have theirs ready to go as well. So thanks, everyone.
All right, guys.
All right,
Take care.
later.
Great case.